My name is Sarah Cuddy. I'm a cardiologist at the Brigham and Women's Hospital in Boston, and I'm the co-director of the amyloidosis program there. So in cardiac amyloidosis, both in TTR amyloidosis and in the more rare AL amyloidosis, we've seen a huge improvement with therapies in the last decade or even less. For now, we have disease-modifying therapies. So we're able to address the precursor proteins that cause the cardiac amyloidosis, either TTR or light chain. So we're able to really kind of stabilize the disease, slow progression of the amyloid buildup itself. So now we really have the opportunity to look after these patients more holistically and address their heart failure needs better. For years, treating heart failure and cardiac amyloidosis, we just solely relied on diuretics, mainly loop diuretics. And that was because these patients really poorly tolerated other guideline-directed medical therapy for heart failure, such as beta blockers, ACE inhibitors, ARBs, because these patients are very preload dependent and intolerant of afterload reduction. So what we see in these patients is that they became quite hypotensive when we tried to introduce other GDMT. However, I think all of us in the amyloid field got quite excited when we saw the evidence behind SGLT2 inhibitors in HFpEF, in heart failure with preserved ejection fraction, and kind of thought, could this mechanism work for our amyloid patients? So I know a lot of us who look after patients with cardiac amyloidosis were keen to start using these medications, even though they didn't have an indication specifically for cardiac amyloidosis. But we thought since this phenotype is more a HFpEF phenotype, hopefully the patients will respond. And I think clinically that's what I saw. And then a lot of groups have been able to translate their clinical observations into observational studies and kind of produce quite compelling retrospective data that shows relative kind of amelioration in NT-proBNP, EGFR, and also trends towards survival, reduced hospitalization, particularly reduced CV hospitalization with the use of SGLT2 inhibitors. So we think this kind of retrospective observational data has even driven us further to use these medications in patients with heart failure and cardiac amyloidosis. So in cardiac amyloidosis, like I mentioned, loop diuretics for years were the mainstay. So a lot of the time, I think we saw an MRA as something that might kind of augment diuresis. And we, again, translating kind of clinical trial data from more generalized heart failure with reduced ejection fraction and preserved ejection fraction, we thought there could be a role. Again, observational data was kind of somewhat positive, and it was really a study from the National Amyloidosis Centre in the UK that showed that there, in retrospective data, that there was a survival benefit in the patients who were on MRA in a propensity scored matched analysis. So again, I think this kind of matched what we were doing clinically. So it kind of led us to say, yeah, I think we should use these medications, MRAs, when tolerated in patients with heart failure and cardiac amyloidosis. So GLP-1 receptor agonists have gotten so much kind of attention for their weight loss value, but also then for the associated cardiac value in giving these medications. However, I think there's really no data in cardiac amyloidosis. And as a clinician, I've been quite reluctant to use this medication in my patients with cardiac amyloidosis, because especially in transthyretin amyloidosis, this is a disease of aging. Patients are often frail. One of their main complaints to me is loss of muscle mass. And we know that there's some kind of degree or concern over degree of loss of muscle mass with the use of the GLP-1 receptor agonists. So I think there's been a reluctance to use these, especially because it would be completely off-label. So really the only data out there that we have is TriNetX kind of database data, which is kind of hard to really not kind of bury down into the details of. So again, implantable hemodynamic monitors, a lot of us think of the CardioMemes device. It like the GLP-1s, really a data-free zone. When I was looking into this for kind of to see what the evidence base behind it was, really I could only find abstracts or case reports detailing the use of these devices in cardiac amyloidosis. But I think intuitively it makes a lot of sense to get these invasive hemodynamic measures, especially when you have a challenging patient to look after. And I have definitely, in my clinical practice, gained huge benefit in using this in patients who've had recurrent admissions, whose fluid balance is very difficult to manage. And they've done really well with the use of an invasive hemodynamic monitoring. So I think probably there's a lot of us out there using these clinically, and really we need kind of the data to catch up with that. Luckily, it doesn't have to be my key take-home message, because there's been 2 excellent documents published only in the last month. One is still in press. One from the American College of Cardiology and another from the European Society of Cardiology Heart Failure Association. And they've put together these expert consensus statements or documents on how to manage various components of ATTR amyloidosis particularly. And they've looked at use of GDMT. And I think their guidance have kind of strongly encouraged the use of the SGLT2 inhibitors, the use of MRAs when tolerated, and then potentially the use of beta blockers with low ejection fraction, and then a lot more uncertainty when it comes to ACE inhibitors, ARBs, and RNAs.